would like to ask a question to the panel, I think. Now we heard a lot about the different typing of HPV and how you should do it. Now we heard the overview of the trials, which are basically stratifying on P16. I would like to ask the people, do they consider the stratification on P16 to be sufficient? Do they consider that we should not include non-all-fine patients into this kind of studies?
Yeah. So I agree with Bill Westra's comment that P16 does not always equal HPV positivity. Even in the case of the oropharynx, you will have false positives. I was comfortable with its use in the design of RTOG 1016 because in many respects it was randomizing patients to 2 treatment arms that were considered within the standard of care. I think it was the first concept of moving toward de-escalation, but not true de-escalation. In the case of, for instance, ECOG, the ECOG trial, in which you truly are potentially withholding curative therapy from a patient with a false positive test, I have tremendous concerns about that. And so in a true de-escalation trial, I would strongly urge that a combination of P16 testing and HPV testing be used for accrual to make sure that we're not undertreating some patients with true HPV negative disease. Anyone else have a comment? Okay.
So all the guys with the protocols are doing wrong.
Pardon?
All the guys who are doing the protocols we just heard about are doing wrong.
Well, many of them are not factoring in the HPV testing. That is true, with the argument being that they're using P16 testing from prior trials to determine eligibility. And because we have a problem in that there aren't any commercially available validated tests for people to fall back on in terms of direct HPV testing. So I agree with you, it's a tricky situation. Additional questions? Well, I think we'll adjourn then, a couple minutes early. And thank you everybody for coming.